Welcome back to the Neurology 101 series on the ProPA podcast. I'm Dr. G, and today's topic is hydrocephalus, a condition where CSF accumulates in the brain's ventricles, leading to increased intracranial pressure or ventricular dilation. This one affects patients across all age groups, from neonates to older adults. Let's dive in. Did you know that the word hydrocephalus comes from the Greek hydro, meaning water, and cephalus, meaning head, literally water on the brain? And while it can sound benign, untreated hydrocephalus can lead to irreversible brain damage, coma, or even death. Let's dive into the kinder patho. What is hydrocephalus? Well, it occurs when cerebrospinal fluid, or CSF, accumulates in the ventricular system of the brain. But why? It either happens from obstruction of the flow, which is considered non communicating, impaired absorption, which is communicating, or overproduction, which is very rare. This leads to ventricular dilatation and, in most cases, increased intracranial pressure, or ICP. The brain becomes compressed, affecting function and blood flow. So, how do these patients typically present? Well, the infants typically present with bulging fontanelles. Remember those soft spots on the front part and back part of the skull. We'll also notice increased head circumference, sunsetting eyes, which happens at a downward gaze, and poor feeding or irritability. In adults, we might notice a headache, nausea, or vomiting. Sometimes patients will have a gait disturbance, cognitive decline, papilledema, and even urinary incontinence, especially in normal pressure hydrocephalus. All right, so how do we make the diagnosis? Well, imaging is going to be our key. We want to get a CT or an MRI, which will show the ventricular enlargement. We also want to look for signs of mass effect or obstruction. We'll perform a lumbar puncture if no contraindications are present, and this may reveal normal or high opening pressure. Special cases include normal pressure hydrocephalus, which has the triad of a gait disturbance, urinary incontinence, and dementia. Remember the W's: wet, wobbly, and wacky. Treatment? Well, for acute hydrocephalus with a raised ICP, we want to elevate the head of the bed, give osmotic agents like mannitol, and consider surgical ventriculostomy or external ventricular drain. For chronic hydrocephalus, we might consider a ventriculoperitoneal or VP shunt placement. We can also do endoscopic third ventriculostomy or ETV in select patients. For normal pressure hydrocephalus, we want to give high volume LP, and this can predict shunt response. VP shunt may improve gait the most, but it's the least effective on cognition. Book med versus street med. So in the book, we're going to see the classic triad of MPH: gait, incontinence, and dementia. For street med, we'll get a 70-year-old man who shuffles in like a little penguin, wearing adult diapers, and his daughter swears he's acting forgetful. A CT is going to show enlarged ventricles with normal sulci. You're thinking NPH, and it might be shunt time. Clinical pearls. Don't tap a patient with signs of increased intracranial pressure unless the imaging is clear. In infants, serial head circumference is a key monitoring tool. NPH may mimic Parkinson's or Alzheimer's. Look for reversible gait changes. Hydrocephalus can occur after meningitis, trauma, SAH, or even tumors. And sunsetting sign in babies is a neuroemergency. All right, now it's time for some practice questions. A 68-year-old woman presents with memory impairment, gait instability, and urinary incontinence. CT shows enlarged ventricles. What's the most likely diagnosis? Is it A, Alzheimer's disease, B, Parkinson's disease, C, normal pressure hydrocephalus, or D, vascular dementia? Well, if you said C, normal pressure hydrocephalus, you're right. So this is a classic wet, wobbly, and wacky triad with ventricular enlargement and no significant cortical atrophy. Question 2. A neonate has a bulging fontanelle, poor feeding, and vomiting. CT shows dilated lateral ventricles due to aqueductal stenosis. What's the best treatment? Is it A, IV steroids, B. Serial lumbar punctures, C. Ventriculoperitoneal shunt, or D. Observation. In this case, the answer is C. Ventriculoperitoneal shunt, or VP shunt. This is an obstructive or non-communicating hydrocephalus, requiring surgical shunting to relieve the pressure. Alright, so some final thoughts. Hydrocephalus is a condition where timing and imaging matter. From the tiniest babies to older adults with NPH, knowing the patterns can help you intervene before permanent damage occurs. In the next episode, we'll dive into the most misunderstood subtype of hydrocephalus, normal pressure hydrocephalus, and its unique diagnostic challenges. If this episode helped you think clearer about CSF and pressure, send it to a classmate or jot down a pearl for your next study session. And remember, this is the Pro PA podcast, where future pros in medicine are made. Catch you in the next one.